Hey guys, welcome back to another edition or another episode of the UK ICU curriculum. We have already done a talk on ARDS, so this is kind of a volume 2. It's the second part. This is refractory hypoxemia in ARDS. So if you haven't checked out the first podcast, or you'll want to listen to that first. And without further ado, let's get into it. Okay, so just to review, the mortality in ARDS is high. So it approaches 50% in people who have severe ARDS. So obviously we want to look for some other reasons to how can we help, how can we improve and help these people that have ARDS. These three principles are very important to understand, and so we're going to spend a little time on it. But this has to do with what characteristics determine how well your body extracts oxygen from the air, from the air around you. So one of the first and most important determining principles is the pressure gradient of oxygen from the alveoli to the blood. So we often think of the fraction of inspired oxygen, the FiO2, but really it's a combination of the fraction and the mean airway pressures. Okay, so just to put this for an example, obviously if you're scuba diving and you run out of oxygen, or you're an astronaut and you're in space and you run out of oxygen, your fraction of inspired oxygen is very low, and so you will become hypoxic. But compare that to people who, say, climb Mount Everest. So when the people are climbing Mount Everest, the percentage of oxygen in the air is still not too much different from the 21% that we're all breathing at ground level. The only difference is that as you climb up the mountain, the barometric pressure decreases. So I think it's between 200 or 250 torr, on Mount Everest. So the idea is 21% of 760, that's what we are at sea level, is a lot higher than 21% of 200. So in those cases, it's not just the fraction, it's not just the percentage, but it's also the mean airway pressure. This is basically the pressure gradient. How much of a gradient of emphasis or pressure is there to go from the alveoli to the blood? Okay, the next issue, pretty simple, is the total surface area. So over how much surface area are you actually exchanging oxygen? There are certain things that can decrease this. So if you've had lung resections or something that happens more dynamically, things like atelectasis. And the third issue is the actual diffusion capacity of each individual alveoli. Now we saw from the ARDS talk that as inflammatory cells build up in the alveoli and interstitial edema builds up, pulmonary edema itself can really decrease the diffusion capacity. But there are other things like fibrosis or emphysema that can also affect the diffusion capacity of the alveoli. Okay, so moving on from that, what are some simple things that we can do to help people who are hypoxic and on the ventilator? Well, obviously the first thing you can do is increase the FiO2 to 100%. That's pretty self-explanatory. The second thing that you can do is you can increase the PEEP. So that is the positive end expiratory pressure. It's as you breathe out, how much pressure is there to kind of stent open, back pressure is there to help stent open the alveoli. So, the more PEEP you have, the more this prevents atelectasis and improves the alveoli surface area. There are some other changes that can do, the PEEP also increases the mean airway pressure and does increase the partial pressure gradient of oxygen. We're going to look at a video of this in a second because there's a really good video, I think, that demonstrates this. The other things that you can do are recruitment maneuvers. These are basically short-term or short little tests or experiments or trials where you use either a high volume or a high pressure to kind of help stent open or pop open some of these atelectatic lung units. So the whole idea is once they pop open, they stay open and they can participate in gas exchange, and thus you'll get better volumes and you'll get better, surface area. There are different ways you can do it. You can increase the inflation pressure, you can increase the PEEP, you can do both. Probably the big thing that you want to do is if you do a recruitment maneuver of some sort, as you return the patient back to their native ventilator settings, you're probably going to want to keep, increase the PEEP. So what you're doing is you've made a change, and as you go back to normal, you want to increase the PEEP so that you kind of help to maintain these hopefully helpful effects. There are some risks to doing recruitment maneuvers. So, it's rare, but you can cause hypotension and desaturation. Those are probably the two key ones you want to look out for. And obviously, anytime you increase the pressure on the ventilator, there's a risk for barotrauma, things like a pneumothorax. Arrhythmias have been associated with this, but again, that's the two probably big ones are hypotension and oxygen desaturation. So this is a little curve. This is a little diagram of what's happening in your lungs and versus what we're talking about. So over on this side, the y-axis is change in volume. The x-axis is the change in pressure. We all know that the change in volume over the change in pressure is the compliance. So this is basically a dynamic curve of your lung compliance. You can see your compliance, the slope of the line is not very good when you're at low lung volumes, and your compliance is actually much better. Is again not so good when you're at the upper limits of your lung volumes, but kind of in this zone in between, the slope improves significantly. So you have really compliant lungs kind of in this mid-range. This is where you want to be when you're breathing natively. If you're on the ventilator, you probably want to be somewhere over here, kind of towards the side of the curve where you don't have a lot of atelectasis, but you haven't quite, maxed out on your pleural pressures. So you can see that over here. This is a lung that has a lot of atelectasis, and as we increase the pressure, well, some more of the lung becomes open and open and open. Now, eventually you'll get, if you give infinite pressure, the lungs will keep getting bigger and bigger and bigger until they rupture. We don't want that. We kind of want it to be in this zone down here where our plateau pressures are less than 30, but we have a lot of lungs open and participating in gas exchange. This video here, I think it's from a New England Journal article, but this is a lung being expanded. You'll see here, as they increase the PEEP up and up, you can see the lung volumes starting to recruit more and more with each successive breath. Here we go. They really increased the PEEPs. Now the lungs aren't deflating as much with each breath going in and out. The lung is actually recruiting these units here. And in a second, in a couple breaths, once they get the lungs fully inflated, they're going to decrease the PEEP down to 0 again, and you're going to see the lungs go from totally inflated to totally shrunken, totally deflated. You have a lot of atelectasis, and even though you're giving the same volume each time, you're not getting as much bang for your buck. So this is what we don't want to see. We don't want to see lungs with this stuff in here. We want them to be nice and inflated and big and open. Okay. So what are some other ventilator changes that we can do to kind of help this? Well, one of the things you often see people do is they'll change the I to E, the inspiratory to expiratory ratio. Normally, as I'm talking, or as you can see, I'm spending most time exhaling. So I take a breath and I can talk for a long, long, long time as the air leaves my lungs. Well, usually on the ventilator we kind of keep that same type of ratio. We have at least 1 to 2 or 1 to 3 ratio. This is where you spend less time breathing in and more time breathing out. That's what would be considered comfortable for most people. Now, when you're super hypoxemic and we're kind of having to make some changes to account for that, we will often shift that ratio the other direction. So you can see here, you can go to 1 to 1. That's the same amount of time breathing in as breathing out, or even 1.5 or 2 to 1. So you spend even more time breathing in and a very small amount of time breathing out. The idea is that this is kind of like PEEP. It's going to improve your surface area by preventing atelectasis. It's going to definitely increase your mean airway pressures. Now, the only catch to this is that when you invert someone and you have them on an I to E ratio that's 1 to 1 or 2 to 1, it's pretty uncomfortable. You can just try doing it yourself. Take a very, very long, slow breath in and then exhale really quickly. That's uncomfortable. So this requires sedation and often paralysis when you get this sick. Okay, so what are some other alternative modes of ventilation? Well, one of them that maybe has gotten some traction over the last 5 or 10 years is APRV, or airway pressure release ventilation. It has different names depending on which manufacturer of ventilators you use, so sometimes there's bilevel or biphasic. It can be patient or machine triggered. It has lots of variables, pressure targeted, but it is pressure targeted and time cycled. Okay, so this is the way it works, is you basically set a high pressure, called the P high, and you set a low pressure, called the P low. You set a time high, or the T high, so that's how long will the person be breathing at this high pressure, and you set a T low, how long will they be breathing at the low pressure. Now, in this picture here, we actually have a pressure-supported breath, so this is a bilevel mode of ventilation. But the idea is, by really controlling both the pressures at the high and, when you're breathing in and breathing out, and controlling the actual ratio of time spent inhaling and exhaling, you can again improve atelectasis and hopefully improve your mean airway pressures as well as your hypoxemia. Okay, so the real big question is does APRV, is it better than any of the other more conventional modes of ventilation? And I guess you can say here, no, not necessarily. These are a couple different studies summarized. You can see, is there a mortality benefit in these? Not really. There are some small benefits of peak pressures, oxygenation, I don't know, vent days, sedation pressures, oxygenation, PDF ratios, but clearly not a mortality benefit. And so I think you can pretty safely say you don't have to use APRV. It's something you can use if you want to try it. There's nothing wrong with trying it, but if your respiratory therapists and your nursing staff are comfortable with it, I think it's okay to do, but there's certainly no impetus that says you need to be using this mode. Okay, so what are some other alternative modes of ventilation? So one is called high-frequency oscillatory ventilation. You can see the abbreviation there. So high flow, or an oscillator, is basically putting someone on with an endotracheal tube in and hooking them up to a machine that will give very small, very, very fast breaths. You can see here, like 90 breaths per minute. I'm sorry, 900 breaths per minute. I mean, we're talking very, very, very quick. This is similar, if you think about it, to kind of the way a dog pants. They're kind of breathing super, super fast in and out, very, very small tidal volumes. So kind of some of the benefits to this, well, I've heard people call it CPAP with a wiggle. That's kind of a good way to think about it, is there's a constant pressure there, and there's just enough vibration that air is kind of moving through, in and out. And this is just kind of a picture of what some of the flow looks like. There's actually really some interesting articles on like how the air moves through the airways, but it's a little complicated and probably beyond the scope of this quick talk. So because of this super high frequency, you get very small alveolar pressure swings. So the idea is you get very little de-recruitment or lung collapse, and you're always kind of propping open the alveoli, and so the idea is that it would help with atelectasis. Typically, when you have someone on an oscillator, they can tolerate much higher mean airway pressures than you can otherwise. But the real question is, okay, so this is a little weird. What are the settings? So you'll see here, there's a couple different things. There's frequency, power, FiO2, mean P airway pressure, the current bias flow. That's basically just how fast the oxygen is blowing through the circuit. You can look here, there's an I/E ratio. So we're going to go over like what all these settings do. So when you're on an oscillator, your CO2 removal is controlled by a couple different things. The first thing is, well, I'm going to ignore frequency for a second, it's the power. So that's how big of a breath you're taking in and out. That kind of makes sense. It's kind of like your tidal volume. Another thing that you can do is you can actually deflate the endotracheal tube cuff a little bit, and you cause an air leak, so the air that's being blown into the system is now being kind of drained back out. That's another way to remove CO2. And the other thing here, which is a little counterintuitive, is the frequency. You would think that if someone CO2 is too high and they're on an oscillator, well, if you go up on the frequency, like how fast the breaths are being given, how fast it's oscillating, that would help your CO2. It actually doesn't. You actually want to slow down your frequency if someone is on an oscillator. The idea is the slower you go, the bigger breath in and out they're going to take. So if you're, just imagine, think of your dog again who's panting really quickly. He's getting very small tidal volumes, and then as he slowly slows down his breathing, he starts taking bigger and bigger breaths. That's kind of the idea. That it's a little counterintuitive at first, but I think it makes sense. And your oxygenation is controlled by your, the fraction of oxygen that you're breathing in, the FiO2, as well as the mean airway pressures, which makes sense. Okay, so again, obviously you're going to sedate and paralyze initially. This is just a little table to kind of give you a comparison between the mean airway pressures and then how you would titrate the FiO2. So does high flow actually improve outcomes? And the answer is probably not. So two different studies, Oscar and Oscillate, looked at this. These are the citations there. Oscillate was actually even stopped early because there was a worsening mortality, more sedation and pressure use, more paralytics in the group that used high flow. There's been the meta-analysis beyond these that kind of support this. So I would say oscillators should not be routinely used for the treatment of ARDS. Inhaled nitric oxide, very controversial, only really because it's expensive. So what does nitric oxide do? You can see here it activates cyclic GMP, and it causes vascular smooth muscle relaxation. So this is a selective, well, it's a pulmonary vasodilator to the alveoli that are actually getting airflow. So you can see here, if you gave someone inhaled nitric oxide, well, the nitric oxide is going to go here and not to the lung that's full of, well, the alveoli that's full of mucus. So what happens is this lung unit, which is we're going to call the good lung unit here, this good little guy here, gets more blood flow because the blood vessels in that area get dilated, and so there's less resistance and you get more blood flow. Whereas this side just stays, you know, kind of, I don't know, I guess I would say the blood flow continues to be poor here. You know, the lung's natural response to an area of hypoxemia is to vasoconstrict and not shunt blood that direction. So this little alveoli here stays, you know, kind of inactive, we'll say. So what are some of the adverse effects? It can cause methemoglobinemia. You can have rebound hypoxemia. Doesn't typically cause hypotension, although it's a theoretical concern. So does it improve outcomes? Okay, so this is why it's controversial. There's been no study that demonstrates an improvement in mortality, vent days, or ICU days, but there are some temporary improvements in oxygenation. So you can see all these studies here. Basically what they say is that there's an improvement in oxygenation that does not persist beyond this kind of short 1 to 2 days, 28 to 42, 24 to 48 hours. So, you know, I guess the idea is nitric oxide is probably not going to be your definitive therapy, but if you have someone who comes in an ARDS and you're kind of temporizing them to do something different, it has a role. I suppose it has a theoretical role. There's been a little bit of a movement towards using inhaled prostacyclin instead of nitric oxide because in theory it does the same thing. It causes smooth muscle relaxation and vasodilation to the ventilated alveoli, similar effects to inhaled nitric oxide, and more importantly, it's much cheaper. Okay, so there are some adverse effects to this, though, although they are less common than IV prostacyclins. So things like hypotension, flushing, musculoskeletal pain, specifically jaw claudications, hypercalcemia, GI complaints. So what does it do? Well, you know, just some studies that show that no real difference in oxygenation, ICU, vent days. It basically works probably about as well as inhaled nitric oxide, but it's significantly cheaper. Okay, so what are some more definitive, I guess we'll say definitive therapies that you can do for someone who has severe refractory hypoxemia and ARDS? So one is called prone ventilation. These are some of the more complicated systems here. There's a rotoprone system, this big kind of you know, padded bed that you can put them in and roll the bed upside down and tilt it, Trendelenburg and all this sort of stuff. There's a pillow systems, this Volman proner system, where you can just lay them on their stomach on these special pillows. Or, and I'm going to show you a video here. This is from a New England Journal article. We're going to skip to, what, maybe up here? Yeah, okay. Or you could just lay the person on their stomach, just kind of as simple as that, you know? That's it. So most of the literature that's looked at proning has actually looked at just laying people prone on their bellies without this complicated pillow system or the rotoprone bed. All these videos are included in the actual PowerPoint lecture, so if you want to look at these, feel free. I'm going to skip them for the time's sake. So what does prone ventilation do? Well, how does it potentially help your patients? So prone ventilation, in theory, reduces atelectasis, improving VQ mismatch. There's a change in the respiratory mechanics and secretion clearance. We're going to go over some of the... There's definitely decreased mechanical compression of the lungs by the heart. Now, it's different because some patients respond really well and some people, you know, don't. There's also this kind of variable response when you turn the patient back to supine. So when you roll them back on their back, some people tolerate that, some people don't. So what are the issues? Why wouldn't you want to use this? Well, it is a little time and labor intensive. There is this concern that, you know, if you have someone who has a cardiac arrest or something happens, like we pull out their ET tube or their line comes out or some sort of problem occurs, it's going to be difficult to fix those while they're laying on their stomach. This theoretically can elevate intracranial pressure. It's usually contraindicated if you have any concerns with that. There is some skin and tissue injury that you have to worry about. And again, this tube and line dislodgement is a big thing because that can become very problematic, particularly if the patient is laying on their belly. So again, does it work? Now there's two older studies that were kind of criticized for using short prone times and high tidal volumes, and then two more recent studies that actually showed an improvement in mortality in severe ARDS. So So it's becoming a little bit more encouraged to use proning in the ICUs, and it's something that I routinely use in people who fit into that severe ARDS category. I usually try to prone laying flat on their belly if we can, and then if we can't, we'll use the rotor prone bed if there's some reason that we need to. Okay, ECMO, or extracorporeal membrane oxygenation. We're not going to spend as much time on this topic as we could. I mean, this is a very detailed and complex. We're just going to kind of summarize some of the key features, compare or contrast some of the different modalities. So, what is ECMO? ECMO is where you take blood and it is drawn through a catheter here. It goes through a pump, through a system. It goes through this oxygenator. It's a silicon membrane oxygenator, and then it's returned back to the patient via another catheter. It can be VA or veno-arterial. That means the blood is taken through a vein and it's readministered through an artery. Or it can be VV, where the blood is taken through a vein and given back to the vein, all on the right side of the heart. Okay, so we're going to go over each one of these individually. So in VA ECMO, where the blood is usually drawn from a catheter in the groin, like in the femoral vein, it is sent through a machine and then it is given back to the patient in the femoral artery. In this circumstance, the blood pressure that we measure with the blood pressure cuff, is dependent on both the pump flow, how much blood is being pumped through the actual machine, plus the native cardiac output, in addition to the systemic vascular resistance. In this case, your CVP is not accurate. And another interesting thing is here, you can see on here as someone is going on the pump, you can see, this is a picture of bypass, but you can see as the bypass flow is going up, you see the pulse go down. That's the whole point is that as more and more blood goes through the pump and you have less going through your heart, well, the pump doesn't have like a pulse. It just kind of continuously pumps through the blood, so you lose your pulse, which is kind of just interesting. It's a weird little quirk of the system. When the blood is readministered, or I guess given back to the patient, it is directed at the aortic valve. This is to kind of help with coronary perfusion. Now, as a result of this, one of the complications is you can get LV stunning and over distension. That's just diagnosed with echo, and you can reduce the pump flow if you need to fix that. Just kind of these little quirks of using VA ECMO. VV ECMO is again where the blood is drawn. There's two ways to do this. You use two separate catheters. One is in the femoral vein, and one is in the intrajugular vein. One draws the blood, the femoral, and you readminister the IJ catheter. Or in some hospitals, you have this one single catheter. We have this here at the University of Kentucky, where the catheter has two different ports. It has one where it actually draws the blood in, and then once it's oxygenated, it goes back to the patient through that same catheter, and it kind of squirts out a different hole. So this isn't really bypass at all. It means that the blood that is going through the system comes back to the right side of the heart. It still has to go through the heart, through the lungs, and then out into the body. So it is really dependent on the patient having a normal cardiac output. You can see here there's no change in the RA preload, PA flow, wedge pressure, cardiac output, etc. You need to have intact cardiac function to do VV ECMO. And because all this blood is coming in and out of the right side of the heart, you can, as you can imagine, get RV dilatation, right heart failure, and that can be a problem because it can affect the left side of the heart as well. And another thing that you can, as you can imagine, this is kind of a picture of recirculation. Depending on how much flow you have going through the system, some of the blood that you're squirting back into the patient that you hope goes through the heart and out to the lungs can actually then get immediately reuptaken by the catheter. We call that recirculation. There's some degree of recirculation that's normal, but the faster and the faster and the faster that you turn up the pump, well, the more blood is going to natively get recirculated. So that can be a problem. That can be a problem that we need to identify and treat. This is a side-by-side comparison of VA ECMO and VV ECMO. So again, VA ECMO provides direct cardiac support, whereas VV ECMO doesn't. But the nice thing about VV ECMO is that you don't have to touch the arteries at all. VA ECMO is at least 2 cannulation sites, whereas VV ECMO is possibly 1, usually 2, but I mean, you can do it with 1 cannulation site. The nice thing about VV ECMO is that if there is a clot in the system and it gets readministered to the patient, the worst case scenario is that it goes and gets stuck in the lungs, whereas on VA ECMO, the worst case scenario is you can cause a stroke, because it's basically squirting in the blood in the femoral artery, and it's kind of shooting up towards the arch of the aorta, and it could go up one of the coronary, one of the carotids. So in VA ECMO, you do have improved coronary perfusion. In VV ECMO, you have decreased risk of cerebral reperfusion injury. We won't go over that, but that's why there's no cerebral reperfusion injury, something you can get really only with VA ECMO. The nice thing about VV ECMO is if you have one of these one cannulation sites, this kind of dual catheter, people can get up and walk around. They're not bedbound, which is nice. VA ECMO is non-pulsatile, VV is pulsatile. VA ECMO causes left ventricular failure and stun, whereas VV ECMO can cause the same thing on the right side. So does ECMO work? That's kind of a lot of talking about something, and you're like, well, okay, so what's the actual, what do the numbers say? And they're probably. So there was this study, the Caesar trial. It was a UK study where they looked at patients who were in the community and developed ARDS, and some of them were transferred to a large, and this is a randomized controlled trial, where some were transferred to a large tertiary care center that actually had access to ECMO, and some of them just stayed in their kind of smaller hospitals, non-tertiary care centers. And they compared the mortalities in the two groups, and you can see that there was actually a significant improvement, a 6-month survival rate of 68 versus 47% in the patients that got transferred to the tertiary care center. There's a lot of potential criticism in that not everyone that got transferred got put on ECMO. So it's not really truly an ECMO versus non-ECMO study. It's really, it's really a comparison between a smaller hospital and a large hospital that has ECMO capabilities and uses it if needed. You can see here there's another observational study where of just ECMO where the survival to discharge was about 70%. So, your overall mortality if you in it on ECMO is pretty high, which makes sense because those people's mortality is already bad if you have severe ARDS. It's certainly something that you can consider if people are getting sicker and you're to the point where maybe you're just trying to decide, is this someone who's weak and prone, or should we try ECMO? And I think most people that have worked in the ICU around ECMO centers have definitely seen people that were quite sick, got put on ECMO, and somehow survived to discharge and have gone on to, do okay. I've personally seen several patients like that. Okay, so that is a quick summary of some of the things that you can do in people who have very severe ARDS, and the traditional measures that we talked about in our previous lecture are not quite cutting it. Again, this is the point of these quick summaries is not to go everything in super detail, but it's to give you some areas that you can look at if you're interested and maybe talk about on rounds and ask some good questions. So I hope this was helpful, and I hope this stimulated some conversation. All right, good luck out there, guys.